I welcome all dignitaries for the mixed bag of paper presentations for today. We'll be listening to six very interesting research papers today. The chair, I would like to invite now the chairpersons for today's session. Dr. Archana Dayal Arya. She is Senior Consultant Pediatric and Adolescent Endocrinology in Sir Gangaram Hospital, New Delhi. Her areas of interest are growth disorders, delayed or early sexual pubertal development, diabetes, and obesity. I also invite Dr. Preeti Singh. She's Professor, Department of Pediatrics in Lady Hardinge Medical College and Kalavati Saran Children's Hospitals in New Delhi, India. Welcome to you both, ma'am. Now I hand over to the chairpersons for inviting our speakers for today. Thank you.
So the first paper is being presented by Dr. Sukruta Surendran. Hello, good morning. And she'll be talking about the association of conventional treatment of hypoparathyroidism and renal dysfunction in children.
Good morning all. I'm Dr. Sukrita from Indira Gandhi Institute of Child Health, Bangalore. My mentors are Dr. Vani and Dr. Rekupati. I'm going to present here my study on the association of conventional treatment of hypoparathyroidism and renal dysfunction in children. So hypoparathyroidism is a rare endocrine disorder characterized by absent or relatively low or non-functional level of parathyroid hormone. Conventional management of chronic hypoparathyroidism involves oral calcium supplementation and active vitamin D. While this approach effectively controls serum calcium level, it often results in hypercalciuria, a non-risk factor for nephrocalcinosis and nephrolithiasis. As a consequence, children with hypoparathyroidism are at increased risk of developing kidney stones and renal impairment over time. So why was this study done? There are very few studies in pediatric cohorts on long-term outcome of patients with hypoparathyroidism, as well as assessing the impact of calcium and calcitriol for prolonged period on renal and its predictors. There are no data from clinical trial that give guidance to optimal follow-up interval or optimal frequency of laboratory and imaging tests in children. So the primary objective was to determine the prevalence of renal dysfunction and nephrocalcinosis in patients of hyperparathyroidism on conventional treatment. Secondary objective was to evaluate the treatment factors associated with development of renal function abnormalities. This was a retrospective study done from Jan 2017 to April 2024 in the Department of Pediatric and Adolescent Endocrinology, IGICH, Bangalore. So the population include those with a diagnosis of hypoparathyroidism. The diagnosis of hypoparathyroidism was based on documented hypocalcemia, hyperphosphatemia with a normal serum creatinine and low or inappropriately normal serum intact parathyroid hormone. The inclusion criteria include those children younger than 18 years of age with biochemical evidence of hypoparathyroidism as mentioned, who were on conventional treatment with a documented follow-up for more than 1 year. We excluded those with transient hypoparathyroidism, coexistent renal disease not secondary to hypoparathyroidism, chronic illness, and those who had insufficient follow-up. So we identified 46 patients with hypoparathyroidism on conventional treatment from our hospital records. 4 patients were excluded, 1 with a chronic kidney disease and other 3 with insufficient follow-up. Remaining 42 patients were reviewed retrospectively. Clinical characteristics including onset of illness, duration of symptoms, associated diseases, renal colic, dose of calcium and calcitriol were all documented. The biochemical test, which was done on each visit with a minimum duration of 3 months, which included total and ionized calcium, phosphorus level, creatinine, 25-hydroxy vitamin D, PTH, urine sport calcium creat ratio were also documented. Urine calcium to creatinine ratio greater than age-specific cutoff was defined as hypercalciuria. For our population, we took 0.2 as the cutoff. eGFR was calculated using modified Schwartz estimation equation, which was used to define renal dysfunction. Renal imaging was reviewed by radiologists for nephrocalcinosis, nephrolithiasis, and renal size. So from coming to results, out of 42 patients, we had 29 males and 13 females. They were followed for an average 5.5 years duration. The most common etiology we found was idiopathic hypoparathyroidism, which was found in 61% of the cases. 14 patients had associated hypomagnesemia at the time of onset, and there were 7 cases of 7% syndromic cases. The most common presenting complaint was convulsion, followed by tetany. There were 3 cases of global developmental delay with convulsion, for which secondary causes were also ruled out. Genetic testing was done in 15 patients, out of which we got 2 syndromic, Opitz GBB syndrome and Griscelli syndrome, and 2 familial hypoparathyroidism type 2 and 1 CASR mutation. 8 patients had associated intracranial calcification and 2 had cataract at the time of diagnosis. All these patients were prescribed calcium with a mean dose of 60 mg per kg per day and calcitriol with a mean of 0.5 microgram per day. So these are the cohort characteristics as mentioned. Hypercalciuria was documented in 71% of the patients. They had a calcium create ratio of more than 0.2, out of which 9 patients had persistent hypercalciuria, accounting to 21%. And we found a significantly higher serum calcium and calcium phosphorus product at presentation as well as on follow-up, and a longer duration of treatment in these patients. Nephrocalcinosis was documented in 4 patients, showing a higher mean serum calcium and a mean calcium phosphorus level. Renal dysfunction was documented in 11%. They had a eGFR less than 90, which was accounting to mild dysfunction, correlating with a higher mean serum calcium, higher dose of calcium, and longer duration of illness. So this is what we described already. In the hypercalciuria and normal patients, there is significantly high level of serum calcium, calcium phosphorus product at the onset, and on follow-up also there is a higher level of mean calcium phosphorus. In nephrocalcinosis and normal USG patients also, there is a high mean calcium and mean calcium phosphorus product. In those with a low eGFR, there is a significantly high level of total dose of calcium and mean calcium. So there is a correlation of eGFR with serum calcium and dose of calcium. There is a significant negative correlation which was found. However, there was no significant correlation of eGFR with nephrocalcinosis and hypercalciuria in our study. The prevalence of nephrocalcinosis in our cohort, 9% of the patients developed nephrocalcinosis, aligning with Saha et al. And Sorem et al., but lower than Levy et al. And Lopez et al. Renal dysfunction, we observed 5 patients with eGFR less than 90, which is comparable to studies like Mitchell et al. And David et al. So renal complications were linked to long-term calcitriol and calcium therapy, as highlighted by Gosnov Moha et al., stressing the need for alternative therapies such as PTH replacement. So here is a comparison of our study with other studies. In this, except for the Levy et al. 2015 study, all others were done in the adult population, and they had a varying range of 7 to 77% renal complications associated with the conventional treatment of hypoparathyroidism. To conclude, conventional management of hyperparathyroidism is effective in maintaining calcium level but poses significant risk of renal dysfunction. So to balance the adequate dose of calcium to maintain serum calcium in the normal range, thereby avoiding high overtreatment to prevent the hypercalciuria is more important. Renal complications including nephrocalcinosis and chronic kidney disease are prevalent in pediatric patients as well. Emerging therapies like PTH replacement offer promising alternative, potentially reducing the renal impact of treatment. These are my references, and this is my team. Thank you. We had these patients follow up every 3 months. Yes, ma'am. Those with insufficient follow-up, we had excluded from the study. And if there was a gap of like more than 3 months, we were taking the time average mean in these cases.
So despite the fact that they were following up and they still, so many of them developed?
Yes, ma'am.
Nephrocalcinosis.
Yes, ma'am. So initially we used to give reduce the dose of calcitriol and advise hydration, and thiazides were also introduced in some of these patients. Some resolved, but some 9% were persistent.
Already have it at the time?
No, at onset it was not there, ma'am. They developed later.
You a question. So, what is the target calcium level that you try to like maintain while the child is on therapy, and what is the treatment that how do you like how often do you monitor these children?
We call them once in 3 months, ma'am. And the range we kept was a low normal range. So 8.1 to 9 was the cutoff what we were following in our department. So to prevent the
So
complications.
sometimes in some of the cases, even if after giving a very high dose of calcium, still you are not able to get these levels.
Yes.
So what do you do after that?
In that cases, we were giving
Because
calcitriol at a
on
higher.
one hand, we are having hypercalciuria, and on the other hand, you are giving the maximum dose to maintain the calcium, and still you are not able to maintain that. So what do you do? Do you go on to some other therapy?
We
Any other
have no
alternative
experience
therapies?
with a PTH so far, ma'am. We were maintaining with calcium and calcitriol. That's all.
Okay.
PTH we were advised, but not yet started.
Oh, thank you.
I think 8 to 8.5 would be, 9 is a little bit higher. Maybe if we keep it there, it would cut down.
Getting on to 8 is also very difficult.
Yes, ma'am.
In these cases.
I think use, except for in certain mutations, hydrochlorothiazide can also be
Helpful in cutting
helpful
down.
in these patients because PTH is not really approved in
Pediatric age group. Yes. Yes, ma'am. Thank you. Thank you so much.
Very nice presentation. So next we have Dr. Sushil Hivale. Dr. Sushil is going to talk on longitudinal trends in albuminuria and assessment of risk factors for diabetic kidney disease in Indian children and youth with type 1 diabetes, a 6-year follow-up from a tertiary care center.
Good morning, everyone. I'm Dr. Sushil Yevle from Jahangir Hospital, Pune, India, and today I'll be speaking on our work on longitudinal trends in albuminuria and assessment of risk factors for diabetic kidney disease in Indian children and youth with type 1 diabetes, a 6-year follow-up. Diabetic kidney disease in children and adolescents with type 1 diabetes puts them at a high risk of developing hypertension and end-stage renal disease. The International Society of Pediatric and Adolescent Diabetes recommends regular longitudinal follow-up of albuminuria in children to look for progressive small increments in albuminuria even within the normal range, which may act as a prelude to the development of diabetic kidney disease. Estimated glomerular filtration rate is important in monitoring declining kidney function and hyperfiltration. Not all children with DKD may have albuminuria, and DKD may thus be classified as either albuminuric or normoalbuminuric, and EGFR is particularly important in these normoalbuminuric children. However, there are limited data on validation of EGFR equations in children with type 1 diabetes. Age-old creatinine-based formulae have poor agreement with urine creatinine clearance. Hence, the objectives of our study were to describe longitudinal changes in the indicators of diabetic kidney disease, that is albuminuria and EGFR, in children and youth with type 1 diabetes prior to the diagnosis of DKD, and also to evaluate risk factors for the development of DKD over a 6-year follow-up. This was a retrospective longitudinal cohort followed up over 6 years from 2018 to 2024. 560 children with and youth with type 1 diabetes attending the diabetes clinic at our unit with a minimum diabetes duration of more than 2 years by the end of the study period were a part of our cohort, whereas children with kidney disease were due to non-DKD etiology, those with celiac, polyendocrinopathy, or long-standing untreated hypothyroidism, and also those with minimum number of visits less than 2 were excluded from the study. Anthropometry, history, and clinical examination findings were recorded. For the urine analysis, the first voided morning sample was considered, and urine for microalbumin by radioimmunoassay and creatinine by Jaffe's method was used, and urine albumin creat ratio was computed. The definition of albuminuria was as per the KDIGO guidelines and was categorized into normal, moderately increased, or severely increased. Mildly increased albuminuria was defined as a urine albumin creat ratio in the upper tertile of the normal ACR values of our study population. Diabetic kidney disease was defined as microalbuminuria or moderately increased albuminuria with a spot urine ACR of more than equal to 30 mg per gram in 2 or more samples collected over a period of 3 to 6 months. Estimated glucose disposal rate (eGDR) was used as a marker of insulin resistance with the waist hip ratio, HbA1c, and presence or absence of hypertension as part of the equation. Estimated glomerular filtration rate was computed by two methods: the new age and gender dependent equations formulated from the CKID study, as well as the old method, which is the modified Schwartz method. At baseline, the median age of our study population was 11.3 years with median diabetes duration 2.5 years. The median HbA1c of our population was 10.2%. If we look at the natural history of albuminuria, at first assessment, 101 children had mildly increased albuminuria, 63 with microalbuminuria, whereas 396 children were normal. Median duration of follow-up was 5 years. If you look at those 396 children which were normal initially, 105 progressed to mildly increased albuminuria, 116 to moderately increased albuminuria, and 175 continued to be normal. 217 children developed moderately increased albuminuria at any time point, from which 67 were persistent and 150 had transient albuminuria. The median diabetes duration at onset of persistently moderately increased albuminuria was 7.1 years. Median age at onset of microalbuminuria was 15.8 years, with the earliest age as low as 3 years. Seven individuals with microalbuminuria later on progressed to severely increased or macroalbuminuria over time, and 98 individuals had a mean annual decline in eGFR of more than equal to 3.3% over time. At baseline, the higher age, diabetes duration, HbA1c, triglycerides, cholesterol, insulin requirement, and late pubertal stage was seen as independent predictors of diabetic kidney disease. When seen together, diabetes duration, HbA1c, and late pubertal stage continue to be predictors of diabetic kidney disease. Over the course of 6 years, age, diabetes duration, eGDR, HbA1c, hypertension, and the presence of dyslipidemia were seen as predictors of DKD. eGDR has also been previously reported in association with DKD from our group in a cross-sectional study conducted a few years ago. Over time, a rising trend was observed in ACR within the normal range even prior to the onset of DKD. However, no such trend was observed in EGFR prior to the onset of DKD. And the same pattern can also be seen in these box plots. So the strengths of our study were its longitudinal nature, a relatively large sample size. However, most of the children from our cohort had a suboptimal glycemic control, and most of the population belonged to the lower socioeconomic class. There was some degree of attrition over the period of 6 years, and since it was a single center study, we could not factor in for the genetic predisposition to diabetic kidney disease, because of which may be because of a lack of diversity in the population. To summarize, patterns of indicators of DKD with predictors were studied over a period of 6 years. Long duration of diabetes, poor glycemic control, dyslipidemia, hypertension, which may be a cause and or effect, and insulin resistance were seen as significant predictors of DKD. A rising trend was seen in urine ACR within the normal range prior to the onset of persistent albuminuria and DKD, and no such trend was noted in eGFR as per both old and updated equations. In conclusion, the lower eGDR was seen as an independent predictor of DKD. Suboptimal glycemic control, dyslipidemia, and insulin resistance are all modifiable risk factors in most individuals, if not all. Targeted interventions may help in bringing down incidence of DKD, and albuminuria as of now continues to be the most reliable indicator of diabetic kidney disease. Future research may be aimed at studying the effect of ACE inhibitors and pattern of growth post-treatment in this cohort of children. If you may allow me, to the bottom left is a picture of the team of doctors from our diabetes clinic. Above that is the entire team at HCGMRI, with every member playing a very important role in the study. And to the right are the little devils, our sweetlings from our diabetes clinic. Thank you. Yes, ma'am. So the median duration at the time of baseline at initiation of study was 3.2 years. Yes, with HM. Yes, that's what we observed.
I have a lot of the history of the
Genetic, yes. I mean, that's yes.
What was the retinopathy status of these children?
Right.
Examination in the children, what was the correlation?
So we have studied retinopathy as well. The analysis was not included as part of this project, but yes, the retinopathy prevalence has also been studied from our cohort.
Yeah, because that may be very interesting. That
Yes,
is one
yes.
of the factors that will decide this DKD, or it is this maybe some other cause for the, like for the adult, it is
Yeah.
40% individuals are diabetes and not having the diabetic kidney disease. There are other way around. So that's why it is maybe important for you.
Thank you.
In fact, a strong association is also seen with the retinopathy and nephropathy. Any other questions?
This urine ACR, what you have produced, it's more than 30. You classify them as.
We classified them to be as microalbuminuria, and in 2 samples collected over a period of 3 to 6 months. We then labeled them as diabetic kidney disease.
By following up these children, we find that some children usually they get relieved of this albuminuria at some stages in their follow-up, and then after a few years they get started again.
Yes.
Do you have any that sort of experience?
We did, yes. So the way in which we manage these children is that the moment they develop diabetic kidney disease, as per the definition, we usually start them on ACE inhibitors and see how they progress. There are some children who revert back to ACR within the normal range, but they are followed up meticulously.
At
Yes.
what stage you start them on ACE inhibitor? Immediately in the mild stage, or even
In the moderately increased albuminuria with a persistent albuminuria, not just on one sample. As a screening modality, we use the spot urine ACR in the morning sample. As confirmation, we do look at 24-hour urine samples as well. Yes.
There are a lot of studies which show that if the patient with type 1 diabetes on the onset cell they start having initially only it is there little,
Yes.
but with time it goes on observed. Most of these patients may be having diabetes onset earlier and they come to our clinics.
Right.
So have you found any correlation like this?
Can you please repeat your question?
No, there are a lot of studies which show that the patients of type 1 diabetes, when they come, they already have some amount of
albumin.
microalbumin.
Right,
It's already
right.
there
Yes.
when it is diagnosed.
Yes. Yes.
So do you have any, this data like this to say that they were already having microalbumin before they came to you, and then you did it and it came a microalbumin?
Right, sir. So yes. So 7 children in our study were already having pre-existing microalbuminuria, and they were also followed up over time. And from them, I'm sorry. So 30 children had pre-existing macroalbuminuria, and 7 developed macroalbuminuria over time. So they progressed into macroalbuminuria.
So what was the disease duration of this patient who had microalbuminuria?
When they followed up, sir, since it was when they came to us, sir, it was a very big sample size. So I mean, the disease duration for those set of children, I may not be able to tell you at the moment. Yes.
Thank you.
Thank you. Thank you. Thanks.
Next, I would like to invite Dr. Ritika Srivastav from LNJPN Hospital, and her paper is on traumatic brain injury and effect on thyroid axis in children, a prospective cohort study.
Good afternoon, everyone. My name is Ritika Srivastav. My topic for today's presentation is traumatic brain injury and effect on thyroid axis in children, a prospective cohort study. The study was conducted in Department of Pediatrics, Biochemistry and Neurosurgery. The funding for this study was by Indian Council of Medical Research, ICMR. TBI in children, as we all know, can cause acute complications, water and electrolyte disturbances, and long-term endocrine disorders. Any critical illness can disrupt the thyroid axis, leading to acute thyroid syndrome. The association between mild TBI and SES in children is less explored. Glial fibrillary acidic protein in recent times has become a key biomarker for assessing neuronal injury in TBI. The current snapshot here shows the involvement of thyroid and cortisol in TBI. And what happens at the cellular level in glial cells during TBI is that deiodinase 2 decreases the conversion of T4 into T3, and deiodinase 3 increases the conversion of T3 into reverse T3. It's basically a protective mechanism, and it promotes the neuron regeneration. There has been a study that shows that cortisol suppression can be seen in approximately 25% cases of TBI, which is basically a dysregulated inflammation or inappropriate response to stress and risk of psychiatric disorder on follow-up. Glial fibrillary acidic protein in TBI is basically a protein that is found in astrocytes, crucial for brain structure and function. It is released during the neuronal damage. GFAP basically serves as a biomarker for study of severity of brain injury. The elevated GFAP levels can detect the brain injury, and it can also aid in monitoring the recovery. Objectives of our study was to measure the incidence of pituitary dysfunction in children with traumatic brain injury in initial 2 years after the injury. We also evaluated the role of GFAP as a biomarker for neuronal injury in children with TBI. The data here presented includes the first year follow-up of a subset of patients. It was a prospective cohort study conducted in Department of Pediatrics, Neurosurgery and Biochemistry for a duration of 3 years. Children with TBI requiring hospitalization were enrolled. Included children were the ones that were admitted within the first 48 hours of head injury. All children who had expired within the first week of injury had any pre-existing endocrine disorder, any known central nervous system disorder, or any major congenital malformation were excluded. All subjects upon the hospitalization were enrolled after giving their consent. The baseline data for medical history, vital anthropometry, and neurological status was recorded, followed by the diagnosis of TBI, which grade of TBI we had. Baseline tests were done within 72 hours after the assessment of TBI. The outcomes were also recorded, treatment of details of any treatment or patient's outcome. Investigation of routine biochemical markers and radiological tests were also recorded. Children were followed up regularly by telephonic check-ins every 1 month, and clinical exams were done at 3 months, and repeated hormonal tests were done at 12 months to monitor the pituitary function and overall health. The additional tests were also done if any patient showed up any abnormal symptoms on the follow-up. 5 ml blood at baseline for hormonal tests were taken, which was done on ECLIA Roche platform, and 1 ml was kept for GFAP, which was done using a ELISA-based method. 2 independent group comparison by t-test was done. Paired t-test was used to compare the trends of laboratory parameters over 2 or more time points. Correlation was done by Pearson's coefficient. So, in total of 193 patients were screened, and 170 were enrolled after fulfilling the inclusion criteria. 23 patients were included due to expiry or loss of follow-up, and 146 patients were there in 6-month follow-up. 38 patients, 1 year follow-up was done till the time we analyzed this data that is being presented today. Majority of our TBI that was recorded was moderate TBI only, with GCS score 13 or above. So the median GCS score was at presentation was 13. Majority of neurological injuries that we found were fracture, which was approximately 88%. The second most was IC bleed, and approximately 48% transient unconsciousness was also seen in the patients. So in a total of 170 patients that we analyzed the thyroid function, 98 patients showed no SES. The thyroid function was normal. 49 patients had SES type 1. 23 patients had SES type 2. A total of 42% patients showed SES. The odds ratio for SES with fracture was 2.915, with a 95% CI from 0.7 to 6.4. There was a positive correlation between GFAP and FT3 and TSH. This data shows the baseline of the 170 patients that we compared and categorized on the basis of normal thyroid function as well as SICU thyroid syndrome. As you can see, the T3, T4 and TSH, they are suppressed. The reverse T3 was elevated in the SES group. There was low cortisol seen in approximately 28% of the patients, which was asymptomatic. There was no electrolyte abnormality or CDI. GFAP and cortisol showed a weak and insignificant negative correlation. On 12 months or 1 year follow-up of these patients, we found out that there was no residual SES. All the thyroid, SICU thyroid syndrome patients had resolved the elevated, suppressed levels of FT3, and all affected 49 patients which had low cortisol also normalized within the first 3 to 6 months. There was a significant improvement in weight for age and height for age. of these patients, probably because of the nutritional counseling and preventing healthcare, and because we were continuously following them up every month by telephonic check-ins, and there was no new fresh neurological deficits found. Children in mild TBI can have associated endocrine axis malfunction at baseline, 42% SES and 28% with low cortisol. CQ thyroid and suppressed cortisol state recovers with time suggesting adaptive response, and elevated GFAP can be used as a useful marker in TBI. Thank you.
It is a nice study. Did you find any correlation between the grading of injury and the endocrinal dysfunction?
Ma'am, actually, the majority of injury that we had was moderate only. Like the GCS score that we had was 13 and above. So our study mostly focuses on mild TBI.
So, what is the clinical significance of your study? What is the clinical significance?
Sir, what we tried was to see that if there is any change in the thyroid function or with respect to traumatic brain injury, but we did not have any severe TBI. We only had mild TBI, and mild TBI had no significant change or no problem in the children themselves. So what we came across was that they had elevated levels of GFAP, which can be said that it is a biomarker, and as well as the SES that we found, which was quite significant in our baseline population, resolved eventually with the follow up.
I just have a question. I might be mistaken, but did you know there was no significant value difference between the cortisol? The p-value was normal in the cortisol in the affected who had, if you go back to that, if it is not there also, but then why do you say the cortisol was low when there was no significant value on analysis? The numbers don't mean anything, no? It just cannot be number. So you had CQ thyroid syndrome, which you proved by your p-value of less than 0.001. I think it was 0.61 for your cortisol values.
Yes,
So you cannot bring that as a conclusion because the cortisol was not actually affected. It was just a difference.
Ma'am, actually, we drew a parallel with the adult study that we saw, which had approximately 25% of the population at baseline had decreased cortisol. And similarly, approximately 28% of our baseline population had decreased cortisol.
No, cortisol value on its own as a number is not an indicator of an adrenal dysfunction. It has to be a stimulated test if you want to prove it is,
Yes,
or
ma'am.
it has to be a significant p-value difference
ma'am.
between both. So that cannot be a final
Yeah,
conclusion.
especially in the younger children too. And did you do the thyroid function after 1 year? You didn't repeat it?
Ma'am, we did. As of
How
now,
did these children do clinically? The ones who did not recover before a year?
ma'am, they were fine. They were. Ma'am, that is significantly improved in both the cases. The weight for age and height for age is actually significantly improved, and that we can say is.
It's a long time for.
Ma'am, actually for TBI with respect to for TBI with respect to endocrinological studies, 1 year is a shorter time period. It has to, whatever changes that have been observed is after 2 years or 3 years.
The ones who were very young also, right?
Yes, ma'am.
Very young children.
Yes, ma'am.
I'm just curious to know.
Okay, thank you, Dr. Ritika.
Thank you so much, ma'am.
In the interest of time, we move on to the next presentation. So next I invite Dr. Amrit Pal Singh from US. Your presentation is on genetic variations in monogenic diabetes or maturity onset diabetes of the young and treatment outcomes. Over to you.
Thank you so much. So I would like to thank a medical student, Igor, who collected the data, and my collaborator, Dr. Ten. I think you heard a really good talk in the symposium about monogenic diabetes. These are excellent understanding pathophysiological situations that we have for understanding not only of genetic diabetes, but also type 1 and type 2 diabetes, as the genes involved are for the receptors for the transcription factors which regulate pancreas function. Generally, it's considered like the rule of one third of patients with MODY, let's just say monogenic diabetes for now, will be treated with diet, the other one third with medication, and the rest will be needing insulin. So that was the main reason why I started to look at our data to see if that one third rule still holds. So the Modi generally is thought to have absence of, especially of severe obesity, but now we're seeing some patients who still have some overweight or obesity, lack of signs of insulin resistance, acanthosis nigricans, family history of diabetes in at least one parent and the first degree relative of that parent, or even a second degree relative would do. Absence of islet cell autoantibodies is measured at the time of the diagnosis, and some degree of preservation of beta cell function with low insulin requirement, detectable C peptide over extended period of time, which has thought to be around 5 years after diagnosis. So, just briefly looking at the genes involved in monogenic diabetes, just like that presentation showed, monogenic diabetes is probably 1 to 6%, according to what reference you look at. And in MODY, the number one gene which is responsible for MODY is GCK, HNF1 alpha, HNF4 alpha, HNF1 beta. And neonatal diabetes is caused by the ABCC8 mutation, KCNG11, and insulin gene and other chromosomal abnormalities can also cause neonatal diabetes. How common is MODY? With HNF1 alpha being on the top, it's reported to be about 50% of all MODYs called by HNF1 alpha, and typically it's a incidental finding. A urine test is done in the clinic, and then glucose is there in the urine without ketones. And further, if you look further into it, there could be presence of HNF alpha. There would be other family members who have diabetes. GCK is also a incidental finding. They usually are asymptomatic and they're hyperglycemic. HNF4 alpha are macrosomic and they have history of neonatal hypoglycemia. Later on, they develop diabetes in the adulthood. So that's roughly about 5%. It's about 1/10 of HNF1 alpha. HNF1 beta is the one with renal abnormalities, and then you can also have rare causes of the sulfonylurea receptor and the potassium channel receptor causing MODY. So primary objective of this study was to look at the patients that we have with MODY and to look at the data and how they were treated, what was their long-term outcome of this treatment. And they fit the criteria for monogenic diabetes according to what we have looked before. And the secondary objective was to look at treatment outcomes and to see if the genetics can tell us what treatment to use. Of course, this was a retrospective chart analysis. We used two academic centers, and these are both academic places which cater to various racial, ethnic backgrounds. It's very diverse part of the United States. And we used the in vitro monogenic diabetes panel for diagnosis. And this not only includes monogenic diabetes, it has other syndromic diabetes genes also included in the panel, which picks up about 28 different genes. The method of data collection was the age of onset of diabetes, family history, BMI, blood pressure, lipid panel, C-peptide, a hemoglobin A1C done before and after treatment. And on average, we looked at 5 years of data. Then we divided the data into 3 different groups. The first group was in which no medication was necessary and patients were followed without any medication, just only with dietary advice. Their hemoglobin A1C actually stayed stable, 6.0 to 6.1% without any treatment. The racial background was mixed. You had Caucasians, Hispanic, and Asians in this group. Age of onset was low at 8.7 because this includes the GCK and the the HNF alpha 1 alpha mutation patients, because these are the ones who are also picked up early. Incidental findings, so they get picked up early, they came to the endocrinology clinic. So that's why the age of onset of this group is younger. There was one HNF1 beta patient, because of the gene deletion, had a syndrome that was picked up early, but usually they also present a little bit later. There were 2 out of the 7 who did not have a family history, and that was one of that was the HNF1 beta, but the other one was the GCK mutation. And this is the ethnic or the racial background, which was mixed. Group 2, these are the ones we're calling it the oral anti-diabetic was used, but there were at least a couple of patients who had the GLP-1 receptor agonist also were used. So these are the ones which typically fall into the age of onset of 20s. So 22, average hemoglobin A1C was 8.7. Post-treatment became 6.4. BMI ranged from 15.5, but you had some heavier individuals in this group as well. But interestingly, all had family history of diabetes. This is an interesting group given the conference because most of the racial background was of Asian descent. So we had patients who were Korean, and if we didn't find, then it was Asian. So this included the GCK. So some GCK patients actually do need treatment, and HNF4 alpha, HNF1 alpha, and there was also a KC and J11 patient which was also treated with metformin without the sulfonylureas. So some of these which are mild also need some oral diabetic agents. Group 3 was the one in which insulin was used, and the hemoglobin A1C was 9.3, but also stayed high at 7.9, and majority of them had history of diabetes. So these included patients who had the sulfonylurea receptor, 4 of them, HNF1 beta, which we know needs insulin, and WFS also needs insulin. So this was not a surprise. But there was still a JCK patient which needed some form of basal insulin along with metformin. Plus, we had HNF1 alpha patients who needed insulin as well. One of the patients had very high levels of triglycerides and was having recurrent pancreatitis, so that could have been a reason for that. But 2 of them were overweight, so BMI could have been a role in needing insulin. This is just looking at, in the interest of time, very quickly at the data. We have talked most about it, but the interesting thing in this data is the C-peptide levels are actually higher in the group which needed insulin. Could have been a compensatory response at that time. And our percentages, prevalence aligned with what has been reported, and this is a very diverse group. So even though across ethnic racial lines, it seems like the percentages of monogenic diabetes is staying the same. There is no one unique gene which is present in one population. It seems like it's all across is the same. The treatment, if you compare it with historically reported and what we reported, about the same, but it seems like some of those milder mutations, so-called milder mutations, are needing insulin or multi therapeutics. The most concluding this presentation, the most important thing was BMI. The BMI was the lowest in the no treated group, went up, and higher BMI in cases of the milder mutations. GCK and HNF1 alpha was probably the reason because of presence of insulin resistance. And also the group 2 were also the Asian descent. So, when you go back to your clinics, you can look for these mutations which are going to be mostly mild and would respond to oral agents. Thank you so much.
People were there from Mexico, from Hispanic, from India, from all over.
Yes.
So did you find any difference in your response or the medication required in these patients or anything with the genes and nothing?
No. Some patients are non-compliant. That's everywhere.
That's the same everywhere.
Yeah, that's same everywhere. Yeah, but no differences in ethnic, racial background as far as monogenic diabetes is concerned. Yeah, thank you.
Thank you. Very nice data. Next, I would like to invite Dr. Anshika Gupta from Kalavati Saran Children Hospital. Her paper is on kidney morphometrics and centile normograms in obese children, cross-sectional study from India.
Good afternoon, everyone. I am Dr. Anshika Gupta. My study was on kidney morphometrics and centile normograms in obese children, a cross-sectional study from India. As we know, obesity is recognized as a serious public health issue globally. The prevalence of obesity has been increased manifold in 6 to 18 years old children. Obesity has been associated with many comorbid conditions like metabolic, cardiovascular, renal, neurological, hepatic, pulmonary, and orthopedic complications. Hence, it is important to evaluate the structural and functional assessment of the visceral organs in obese children to identify chronic illness at an early stage. Obesity has been identified as a risk factor for disease progression in those with pre existing kidney impairment. Kidney size is an important parameter for the diagnosis of renal disease. Previous studies have reported that obese children have larger kidneys. So, the application of normative kidney size data of healthy children to obese population may lead to a misdiagnosis of end-stage renal disease in obese children and an erroneous diagnosis of nephromegaly. The studies on kidney size in the obese population are very few. To the best of our knowledge, there are no published nomograms of kidney size from an obese Indian population. So, the objective of our study was to assess kidney morphometric parameters and to develop centile curves in Indian children with obesity aged 8 to 17 years. Our study was a cross-sectional study done in the Department of Pediatrics and Department of Radiology in a tertiary care hospital in New Delhi from a period of November 2022 to February 2024. We enrolled children of age group 8 to 17 years who fulfilled the criteria of obesity according to the Indian Academy of Pediatrics 2015 growth charts as an BMI equivalent to 27. We enrolled a total of 125 children with obesity and we divided children in each age group categories with the 25 children in each age group categories at 8 to 9 years, 10 to 11 years and so on. We included children of 8 to 17 years with simple obesity as per IAP 2015 growth charts. We excluded those children with pre-existing non-acute kidney injury, chronic kidney disease or connective tissue disorder. We also exclude children with non-cases of pathological obesity due to endocrine, genetic, syndromic causes and the obesity due to drugs. We also exclude children who have a history of recurrent urinary tract infections or having active urinary tract infections. We also exclude those children who were found to have structural abnormalities of kidney on ultrasound or having proteinuria with urine dipstick of 1 plus or more than 1 plus on 2 or more occasions. So briefly discussing about the study procedure, all those children who fulfilled the inclusion criteria were enrolled in the study, informed consent was taken, then the demographic profile of the patient's epidemiological characteristics, dietary and nutritional history was taken, and anthropometric measurements like weight, height, body surface area, BMI, and waist circumference were measured, and a screen for related comorbidities like hyperglycemia, hypertension, and NAFLD was done, and the ultrasonographic measurements of bilateral renal parameters were done in all children, followed by data analysis. So we enrolled a total of 126 children with obesity, out of which 61% were male and 39% were female, and the age distribution of our study subjects are as shown. On the renal size measurements, these box plots shows that the median renal length and volume was progressively increasing for the age, as well as the left renal length and volume was also found to be progressively as the age. We compare the effect of gender and laterality on the kidney size. We found that there was no significant difference between the kidney size of male and female children. On comparing the parameters of right and left kidney dimensions, however, we found that the left kidney dimensions were larger than the right kidney dimensions, and it was consistent with the previous studies which have shown that left kidney dimensions were greater than that of the right. We also correlate the renal size parameters with various anthropometric parameters. We found that the kidney length had a better correlation than the kidney volume. Also, the both kidney length and volume had a positive correlation with all the parameters, with a strong correlation with the height, BMI, and height, body surface area, and waist circumference. We done the quantile regression analysis to find out the significant predictors. On univariate analysis, both age and BMI was found to be significant predictor of kidney size. However, on multivariate analysis, only the age was found to be the significant predictor. Hence, we proceeded to make the age-based centile charts in obese children. We also conducted a pilot study in 21 children to find out the inter-rater reliability, intra-class correlation coefficient, and blind Altman analysis was done. The ICC was came out to be excellent with a value of 0.98. Also, the blind Altman analysis shows that the width of limit of agreement was within the acceptable range. So we constructed age-based centile charts and normograms for the renal size parameter. Using the Coles lambda mu sigma model, we made age-based centile charts of renal length and volume. So in our study, we developed normograms of kidney size in Indian population with obesity in the age group 8 to 17 years. The kidney size had a positive correlation with height, weight, body surface area, waist circumference, BMI, and age. There was no significant difference found between the kidney size of boys and girls. In comparison of the right and left kidney sizes, left kidney dimensions were significantly greater than that of the right kidney. Age was a significant predictor of kidney size. Therefore, age-based centile charts were constructed for kidney length and the volume. So the strength of our study was that we take into account the Indian population of obese children classified according to the IAP guidelines. To our knowledge, no prior study has been conducted on obese children in the Indian population. We also calculated the inter-rater reliability. This was the first study to develop centile charts for obese children, which serve as a reference for future research. Also, we made normograms based on kidney volume. However, the limitation of our study was that the sample size was too small to generalize result to the broader population. Also, we did not compare the renal size parameters of obese children with the non-obese children. However, we plan to conduct a similar study in the future, taking the non-obese population in our study. So as we way forward, these centile charts can be used as a future reference for assessing renal parameters in obese children. This will decrease the chances of erroneously being diagnosed as nephromegaly in obese children and will pick up the end-stage renal disease at an early stage. Similar research should be conducted using a larger sample size to enhance the precision of the results. Thank you.
Since you don't have the normative, do you have can take from historical or from the literature that how is it different?
Yes, sir. So we did the literature review, but in the Indian population, there was not so much nomograms even based on the normal non-obese children. The age group was the 0 to 12 years and the sample size was not so big. So we could not
And quickly,
compare.
the another thing is generally the renal size is correlated to the length of the vertebra. So generally it is considered 2 vertebrae is equal to the length of the kidney. So is there anything you did in your analysis that might be useful? Because
Sir, it is, but we did not correlate the length of the vertebra in our studies. Yes.
I have two comments, and really, first of all, your population selection for designing nomograms is slightly questionable, because whenever you design nomograms for any parameter, you must take a healthy population rather than skewed population. That is one. And very quickly you went through the slides, but I could see that the 97 percentile was way high and all over the place. When you are designing a parameter or a centile chart for something like a kidney, use of LMS method is not the best way. You should have used Gambless method, because it's far more generalized than LMS is specifically meant for height, weight, BMI. So
Yes, sir.
so you could perhaps improve on that as you go.
Thank you, sir.
Thank you for your nice talk. I have a question about the functional implication or the clinical implications for this work. I guess thinking in the clinic, does it matter and maybe this is a crude way to say it, doesn't matter if obese children have bigger kidneys, we're not going to use that as a predictor of end-stage renal failure because it's still not going to replace urine protein and blood pressure measurement in determining when we would start renoprotective therapy. So I guess I wondered what situation you thought that this might be of clinical utility.
So, this might be of clinical utility in those children in which we measure the normal kidney size. So, the obese children might be missed because we would compare the normal. We would be applying normal data of the normal size of the kidney to the obese population. So, if they are having the end-stage renal disease and if they are having a smaller size, those population will be missed. So, to pick up those children at an early stage, so the nomograms based on the obese population will be helpful.
Thank you, Dr. Anshika. I think we cannot take more questions because we are running late. Right.
Thank you so much.
Thank you for a nice presentation, Dr. Anshika. We move on to our last presentation by Dr. Muller. Dr. Muller will be speaking on epidemiology of hypothalamic obesity in craniopharyngioma and other rare cellular and supracellular tumors. Welcome, Dr. Muller.
Thank you for the kind introduction. Dear colleagues, most of you know that several tumors, such as these depicted here, might be located in the cellular and cellular area. So just recently we were asked in a review to give information about prevalence and incidence of hypothalamic syndrome. And that was really difficult because there are no good data on these parameters, especially due to the rareness of the diseases. This is even worse when you are looking at hypothalamic obesity. And we wanted to do the analysis of this hypothalamic obesity in a German data set. And the great problem is there is no coding for this in the German data collected by the health insurances. So designing an algorithm to identify these patients, we were aware that patients with diabetes insipidus are more likely to have post-surgical weight gain and greater hypothalamic damage on MRI, particularly in the posterior hypothalamus, and that diabetes insipidus does not directly cause hypothalamic obesity, but serves as an endocrine marker of hypothalamic damage. And this flowchart depicts the way of this algorithm with which we designed. We had 5.4 million data sets of patients, and these patients were representative of the German population. And first we looked at patients with tumors of the cellular area which were operated or got radiation therapy, and that limited the cases to 3,976. And then after this index event, we looked at patients who developed obesity, and these patients had also to develop a diabetes insipidus, and they had to get prescriptions for desmopressin, and that resulted in 37 patients who fulfilled the criteria for hypothalamic obesity. This table shows you the diagnosis, mainly benign tumors of the cellular area, and you see also the craniopharyngiomas here included with pretty high numbers. And looking at the incidence, we saw that the incidence of hypothalamic obesity was ranging between 0.7 and 1.7 million cases per million population per year. And we had actually 2 age peaks, one at an age of 10 to 14 years in the pediatric cohort, and a second age peak at the age of 40 to 44 years for hypothalamic obesity. And it was really important when we checked the data to include the diabetes insipidus in the algorithm, because not doing this, the numbers are way too high and not reliable. We also looked at economics and healthcare resource utilization in these patients we identified, and we compared the data with in a matched pair control analysis, and the ratio was 1 patient with hypothalamic obesity matched to 10 patients with non-hypothalamic obesity control. And as you can see here, this shows you the average number of healthcare utilizations compared between patients with hypothalamic obesity and obesity patients without hypothalamic origin. You see that patients with hypothalamic origin on the lower lines, also inpatient and outpatient, had much more healthcare utilizations in comparison to the other obesity controls. And what about the costs and excess costs here shown in euros that were in the first year 20,000 euros excess costs for patients with hypothalamic obesity when compared to obese patients without hypothalamic origin. In the second year 10,000, and I checked it by the calculator. It's about almost 2 million Indian rupees in the first year. This shows you the same data graphically shown, and you see here the data for the hypothalamic obesity cohort in comparison to the normal obesity cohort and the general population, and especially in the early beginning in the index event, doing surgery that costs a lot of money. And this is also seen here when you look at inpatient costs and outpatient costs. We have high costs doing the surgery, but also post-surgical, there are high costs in treating these outpatient on an outpatient basis, and they are mainly caused by prescription costs, as you can see here. And we looked what is prescribed, and once again here you see the average cost per prescription when compared between hypothalamic obesity and non-hypothalamic obesity. They were definitely higher in the group of patients with hypothalamic obesity. And the reason for this high cost is the prescription of hormones, especially somatostatin, somatotropin, growth hormone. So our results show that tumor treatment-related hypothalamic obesity patients have elevated healthcare use in all sectors compared to non-hypothalamic obesity control patients. The economic burden of hypothalamic obesity is characterized by high excess inpatient costs due to follow-up hospitalizations, consistently elevated excess outpatient costs, and a dramatic increase in excess prescription costs in the second year after the index event. And prescription costs are driven by the need for ongoing hormone replacement therapies. So we conclude maybe a cost reduction might be possible by centralization of treatment, with a question mark. Novel interventions and pharmaceutical agents for more effective treatment of sequelae due to hypothalamic syndrome and obesity are warranted. More research on treatment pathways is necessary, and a more comprehensive characterization of hypothalamic obesity patients will be crucial in developing optimal treatment strategies to improve patient outcomes. Thank you very much.
I have many patients with panhypopituitarism who also develop hypothalamic obesity. And any comment on that? I know it's not related to your.
Actually, we have a close look to hypopituitarism because we are checking whether the patients receive adequate hormonal substitution. And we are aware of the fact that the problem of hypothalamic obesity and hypothalamic syndrome is very specific and actually not related to hypopituitarism, where we see problems in patients who are very well substituted and they have problems in circadian rhythm, in blood pressure, in temperature regulation, and so on.
Sleep is also important.
Yeah.
Thank you.
And the data, the epidemiologic data, are very specific for German population, but right now we are starting to do it also in other populations, in the Japanese cohort, which is much bigger, and we see that it's essentially very important to include this diabetes insipidus thing, because in most data sets you find so many other reasons for obesity that you have to look for a specific criteria for hypothalamic obesity. And hypothalamic damage is not coded in the data usually.
Thank you, Dr. Muller. It was an excellent talk. Thank you so much.
Thank you.
I thank all the speakers for sharing their valuable research findings with us. Dr. Mueller for sharing his data, valuable one, longitudinal data from that is very rare to for us and very valuable for us that was shared with us, and our young researchers to share their very enthusiastic and novel research ideas. This was really a mixed bag of presentations. So now I request to invite Professor Meena Mohan to please felicitate our chairpersons, Dr. Archana Dayal Arya and Dr. Preeti Singh. Now we all have to proceed to the basement hall where the further sessions will be conducted. I have few announcements to make for all those who are here. Do please collect your lunch boxes before leaving from the exhibition hall, and the certificates will be sent to you within 7 days of receiving your feedback Google form responses. And all the conference photographs will be available on the conference website after 3 working days. Thank you.